going to be covered today on this particular webinar. Today we're going to cover the utilization management or utilization review criteria for clients who are already in adult state plan services in New York City on October 1st. So whether it be an OTP or a PROS program or a mental health or substance use clinic program, these are for clients who are already in those existing programs as of October 1st. A little later in the webinar, we're going to go through exactly what the eligibility criteria, which makes you existing versus a non-existing client in those programs now. But just to be very, very concrete, it is for state plan service clients who are already in existing programs as of October 1st. It will not cover new clients who start those programs as of October 1st, and will not cover or utilization review criteria for adult HCBS programs, and it will not in any way cover any child serving programs. So it's New York City only, state plan service only, existing clients only, and does not include HCBS. So I just want to be very, very clear about that. We're going to talk about when those other issues are going to get addressed at the end of the webinar, but I just want to be very, very clear to make sure that everybody understands exactly what we're going to be covering today. We're going to talk through the actual content of this is going to go very, very quickly. And then we're going to take as many questions as possible. Our state partners are going to have to drop off at 10:30 and 10:45 respectively. So we're going to try to get in as many questions as possible. We may be somewhat selective in choosing the questions that come in or choosing the questions that we address to address the specific issues that we're going to talk about today. But I just want to be real clear about what we're going to cover today before we get started. So I'm going to get started now, and we're going to go through the content pretty quickly and then take questions. But as questions come up, please chat them into the chat box as you have them, and we'll keep a running tally of the questions as they come in and then ask them as soon as we get through the content. So I'm Andy Kleek. I'm the director of the Managed Care Technical Assistance Center. And our goal really is to work with all mental health and substance use providers in New York State, really helping them to make the transition to managed care. At this point, we've worked with really the majority of providers around the state, and most providers in New York City as well. Our efforts are really centered around the McSilver Institute at NYU, where I work, in Costa Columbia, and together we kind of form the core of this. And we also have a number of other key partners, including CCSI and ICL and NIAPRIS and NYU School of Medicine's IDEAS Center. So the programs listed here, and I'm not going to read through all of them in depth, but the programs listed here are the programs that are transitioning into managed care on October 1st for New York City and then July 1st for the rest of state. It includes all the inpatient psychiatric services in Article 28 clinics, which we are explicitly not addressing today. We're only going to talk about ambulatory services today. It was the one thing I didn't mention. 599 clinic services, behavioral health services, and 598 integrated clinics, PROS programs, CDT programs, IPRT programs, ACT programs, as well as OASIS clinics, opioid treatment programs, and OASIS outpatient rehab. So really all the state plan services are being carved in on October 1st in New York City. I'm also not going to go through this in incredible depth today, but this will be up on our website with the rest of the slides after the webinar today. And this just highlights who's in and who's out. We like to say this is our who's on first slide. But basically the big blue circle is all the state plan services that are being carved in, and it also highlights where things are specifically out or whether specifically populations that are definitely included. So SSI non-dual clients are definitely carved in. HARP clients, which are a subset of clients, will be harped in, and I won't get into the nuance of HCBS stuff in there today. For clients who are dual Medicaid, Medicare clients are excluded from Medicaid managed care and will continue to be billed free for service as of October 1st going forward. There's a even smaller subset of those clients who are in a CMS demonstration project with New York State called FIDA, and we're not explicitly directing that, but there are some folks who might be in FIDA, and they are excluded from this managed care transition, but they're in the FIDA demonstration. Children's services, clients who are between the ages of 18 and 20 are also excluded and will be carved in with the children's services in 2017. And the other very small pieces that are carved out include Medicaid buy-in, spend down, and folks who have both commercial and Medicaid at the same time. So, and also OPWDD is also excluded from HARP. Okay, so with that, I'm going to turn it over to Boris Vilgorin, my partner in crime, who's going to walk us through the eligibility criteria.
Hi, good morning, everybody. So the first bullet is really the same thing that Andy just went through, but in words instead of a picture. The one that I really want to focus on is the second bullet that's labeled managed care and HARP status can be confirmed with EPACES. So we get a lot of questions about EPACES and how to, and how to find, what insurance and or HARP status. So for Medicaid providers, this should not be anything new. You should have been using and are probably using EPACES for a long time and very familiar with it. That's where all the insurance status is. Our understanding is that the HARP status is also there, and again, even though we're not focusing on HARP, we just wanted to point that out to folks. And to be very clear, the individuals that are transitioning, as Andy pointed out, for most part, if not all, are already enrolled in managed care. For a lot of you, you might not be aware of what managed care because your services were carved out or the individual was carved out from behavioral health services, but it did not mean that they were not in managed care for their physical care services. So when you go to EPACES, you should be looking up what managed care company they're already enrolled in. Again, if they're duals, they might not be enrolled in, and if they're under 21, they will not be enrolled in or potentially not enrolled in. Also for Beacon, the plans that are covered through Beacon Health Options, Beacon will not be listed on EPACES. That's important to just underscore. The plans will be listed. So it's important to know which plans are covered by Beacon, plans like Affinity and Emblem and MetroPlus and so forth. But if you're looking at EPACES, you will not be finding Beacon.
And you can also, if you have a question of whether a plan is covered by Beacon or not, you can go to our matrix, which is on the MCTAC.org website, and you click on the matrix, and it'll identify under the plan information whether they're being covered by Beacon or not.
Okay. So the next slide is, so we thought one actually suggestion was made is to create a quick, really brief workflow to kind of determine who's in and who's out of this discussion here. So the first thing that providers should really be doing is checking the status of their individuals that they're serving. Are they included or excluded from it? And again, if they're excluded, like duals, there's no change in their status. You continue as is. That's kind of going all the way through the right. If they're included, meaning they do fall between, the ages and everything else that we talked about, the next question is, are these new clients or existing clients? If they're new clients, we'll be doing a utilization management presentation training in early October. We'll talk more about it at the end of this presentation. So if it's new clients, they go that route. If it's existing clients, then again, we will cover the definition of existing clients in a couple of slides or so. Then you go to the next level. And the next level, you want to ask, are you as a provider in network or out of network? Meaning, do you have a contract with that particular managed care? And depending on if you have a contract on October 1st or not, and again, we'll cover it in the presentation, you will follow those particular flows. So with that kind of flow, you will be determining, where do you fall, and hopefully it's helpful to kind of bucket the individuals that you're serving.
Okay. Tom. So with this, we're going to turn it over to Tom Smith, who's going to walk through the definition of how you identify whether somebody's one of your continuing clients. And I would just encourage people as we go through this to chat in their questions as we go, and we will answer them at the end, but chat them in when you have them so we can keep track of them. So with that, Tom, I give it to you.
Hi, Andy. Thanks, and good morning, everybody. I'm Tom Smith. I'm the Medical Director for OMH's Division of Managed Care. And just want to touch on this in detail, this slide, and I think it's worth reading. This is the definition of a continuous behavioral health episode of care. These would be cases where there's a course of ambulatory behavioral health treatment, excluding ambulatory detox and withdrawal services, which began prior to the effective date of the behavioral health benefit inclusion, so that would be October 1st, 2015 for New York City, in each geographic service area, in which services have been provided at least twice during the 6 months preceding the behavioral health benefit inclusion day. So at least 2 services prior to October 1st, within the prior 6 months, by the same provider to an enrollee for the treatment of the same or related behavioral health condition. That is going to be our definition for the continuous episode of care. Now, and I think the regulation, the policy we're putting in is that the plans cannot apply utilization review criteria during this 90-day period. In a sense, what that means is that the plans cannot issue medical necessity denials during that period of time. It's important, however, to emphasize that that doesn't mean you won't necessarily be talking to the plans. We've really emphasized with this rollout that we want the behavioral health plans to do a lot more than just apply UR criteria, medical necessity criteria. We want a person-centered, recovery-oriented focus to management. We have health homes, we've got all these DSRIP projects, we've got a lot of new reforms, and we want the plans right in the middle in terms of helping coordinate and manage care. So if you have a complicated case, the best example might be inpatient case, right? If someone's admitted before October 1st and is in the hospital for 90 days, that person has a very long length of stay and probably has a very complex discharge plan, maybe awaiting transfer to a state hospital. We would hope and expect that that inpatient provider would be in touch with the managed care organization so that that care manager, the plan care manager, can help with that disposition plan. So it's not, the 90-day rule is not a blanket ignore the plans. It's no medical necessity denials, but work with the plans. All of the providers have contracts with the plans, and most of these contracts do have notification requirements. And that's important. Notifying a plan is different from requesting prior authorization or concurrent review authorization. We strongly endorse the plan's notification requirements and strongly emphasize that providers should consider submitting rosters of enrolled people and contacting the plans as of early October to let the plans know where people are, what kind of services they're getting. Plans cannot do the kind of care management that we want if they don't know where the people are. So please communicate with the plan care managers, let them know who's getting what types of services, and ask for their help as indicated. We've made it clear, we've also made it clear to the plans that they cannot deny upon lack of notification. In the past, that's been a practice nationally. We don't want that, but we've also said to the plans, we're going to strongly support their efforts to ensure that there's proper notification of where clients are and what kind of services they're getting. So we really do support this notion of notifying the plans, letting them know what's going on. All right, I'll stop with that.
Okay, that's great, Tom. So I just want to review the definition of an existing client to just be real clear. So what it says here is that the client has to have received at least 2 services in the last 6 months by the same provider for the same diagnostic behavioral health condition. So that's and the notification requirements are separate from utilization management, and so folks will be expecting to be speaking with the plans, and these are the requirements. So I just want to hit the takeaways, and then Pat, I'm going to turn it over to you for the next slide. Here we go.
I'm sorry, guys. I was. Can you hear me?
Yes, we can.
Yes, we can. Okay, thanks. I wasn't sure if I was muted on your end or mine. Okay. So the 90-day transition language prohibits plans from applying utilization review criteria, and I think Tom said that. So for the people who have met that criteria of being an existing patient, that utilization criteria, you can't expect a concurrent review or medical necessity denial during that period of time. There's also 2-year continuity of care language. And what that does is it affirms that the plans must permit enrollees to continue receiving services from the current provider for continuous behavioral health episodes of care. And that is defined in the model contract for a period of up to 24 months from the date of the behavioral health benefit inclusion in New York City, or when that transition happens in the rest of state, for the rest of state as well. The plans may use, that will make you approved UR criteria during those, that 24 months, and for a WASAS, that would be locator. So what this is saying is that 2 years of continuity. So you have somebody in your program, you don't have a significant number of that plan's members in your service, but you do have that patient who has been with your program, and this allows you to continue to work with that person for up to 24 months. So by up to 24 months, if that person were to discontinue care with you and come back, and the actual month is determined by the medical contract, that would be a new episode of care, and the 24-month continuity would not apply. So you do not need a contract with that plan, but that plan must pay for that service for existing patients. Generally, that happens on a case-by-case kind of a basis, but the plan is required to honor that, and they're required to pay the state government rate for the services.
That's fantastic, Pat. And just to reiterate, so no UM or UR criteria for the first 90 days for the existing clients as defined by Tom. So no criteria, no UM or UR criteria for those 90 days, and that clients can stay with the same provider for up to 2 years as long as it's the same episode of care after 10-1. But after 90 days, even with that same provider, then UM and UR criteria would kick in. And also, if the provider is out of network at either on 10-1 or going forward for a particular plan, that's the two-year window. The plan would still have to pay you as a provider for up to 2 years, but after the 90-day window expired, they could, come back around medical necessity and those kinds of things. So I just want to clarify that for folks. Okay. All right. So I'm going to jump through. I'm going to jump through the rest of the presentation in about 30 seconds to a minute. But while I'm doing that, please feel free to continue to chat in your questions, and we're going to come back and ask any questions that we have of Pat and Tom. So I'm going to go through real quick, and then I'll come back in just a minute, and we will take questions. So just on the other issues that are coming up, so just the for existing, not for existing clients, but for new clients going forward from October 1st going forward, we are going to be doing training on October 5th and 6th at the New York Bar Association. We will be getting out registration materials in the next day or so. So please look on your email for that and get signed up. We have capacity to accommodate, I think, 800 people or 600 people on each day. We are actually going to break up them into morning and afternoon sessions. We'll do the morning or afternoon on OMH and the opposite for OASAS. It's the one area where we're breaking the two service systems up, because if you're only an OASAS provider, there's no reason to sit through all the OMH-specific criteria and vice versa. And also want to highlight for folks our matrix again. It is at MCTAC.org, MCTAC.org, which is listed on the next slide. So all of our information and this presentation will be available at MCTAC.org. If you go on MCTAC.org, you can click on our matrix. It's right on the front. I think it's on the front screen. It has all the information, the specific information for the plans. If you have questions, you can send them to mctac.info@nyu.edu. So I'm going to pause there, and we're going to go back through and start answering questions. So the first question is, because I saw it before as it came in, I want to make sure we hit it. Okay. If the plan provider agreements are not fully agreed upon or executed by 10-1, what happens at that point? Pat, I think you and I both said this, but if you want to just take that one and quickly highlight it again for the continuity of care piece, I just think it's a question that people are going to want to make sure we get answered real clearly.
Yeah, so if you don't have a contract in place with that provider, you still, and you have a patient who's in care with you, the plan has to pay for that service. However, one of the things that you should understand is that you need to have an agreement with each of the plans that you're dealing with on this per client kind of a basis. So each plan may handle that a little bit differently. So you should be reaching out to the plans if you're not in contract and you have members in your care currently. But the continuity of care requirement requires the plans to pay for services up to 24 months for anybody who will be in your care as of October 1 for whom you don't have an in-network contract with.
So just to highlight what you said, Pat, that you have to do something. You're going to have to reach out to the plan and come up with some kind of arrangement by which you can get paid, but they are obligated to pay you for those services within the 90 days and as long as it maintains the thing. Now, another question came in along those same lines for either Pat or Tom or both. What criteria defines the same episode of care? I think one of you had said, if somebody stops and then doesn't come back, and then tries to come back, they follow the new criteria. What if there's a dispute in that area was one of the questions. How does a dispute get handled about whether it's a new episode of care or a previous episode of care?
This is Tom, I don't think we've addressed that question directly, whether there are disputes and how they would be managed. We have talked about the definition of a same or related condition. I don't think we have final language on that. I think we wanted to sort of put this out today and see what kinds of questions came in. If there's a lot of questions about the definition and need for more clarity, I think we'll respond, but we haven't developed specific protocols yet. Is that accurate, Pat?
Yeah, no, absolutely.
Yeah.
Go ahead. Sorry, Pat.
No, Andy, I was just agreeing with Tom that there is language in the contract that speaks to, the episode definition, but in terms of if there were a dispute, that would be managed, I think, in the same way that, first of all, you would contact a plan and then, go through a process with the Department of, notify Department of Health that there would be a difference. I don't think that this is one that's going to lend itself to a lot of disagreement because the definition is pretty clear about who would be a current client.
Okay, great. And there have been a number of questions that come in about health homes, and I'm going to just highlight that we're not going to address health homes today. That particularly around the plan of care, we will be doing training on the plan of care and other issues around HCBS, but that we're not addressing HCBS and or health homes today. Just give me 1 second, and I'm going to kind of come up with the this is actually a really good question. I think it's a pretty good answer, but a really good question. Will we continue to bill state Medicaid for services prior to 10/1? I think the answer to that is yes.
Yes.
Okay, if we have an existing client prior to October 1st who will need to have their visits authorized, we have up to 90 days to get authorization for those visits beginning on 10/1. No, there's no authorization from 90 days going forward. This does not apply to commercial clients who might be a whole other separate thing. So for existing Medicaid fee-for-service clients who transition into Medicaid on 10/1, there is no authorization process between 10/1 and I guess January 1, 90 days. But with Tom's caveat that plans are going to request notification and want to talk to you in the meantime. There was a question just around contracting, and if you haven't heard back on contracts, how do you suggest you get the plans to respond? I would go to our matrix and reach out to the folks who are listed under contracts for that, and we can do that. A couple questions around authorization. Do we need authorization from the plans for the first 90 days for existing clients? As per the definition we just went through, you do not. For new clients, there will be different requirements, and we'll deal with that on 10.5 and 10.6. Let's see. How will, Pat, this is probably a good question for you. How will plans handle mandates for criminal court judges, probation and parole?
So from a utilization standpoint, the locator allows for an override of the level of care for a court-ordered reason. So nothing replaces the current law that states that a court order can supersede medical necessity. However, we are working with the drug courts and other criminal justice entities so that they understand the locator, have access to it. We're requesting that they utilize it themselves so that everybody plays from the same kind of sheet of music here, so that there's an understanding about the medical necessity. We, as a state agency, don't want to see people in the wrong level of care. So we, however, there is nothing about the change to managed care that changes the, the plan's requirement to pay for services that are court ordered.
Great, thanks so much. And then another question came in, and when you state need to have an agreement on a per client kind of basis, does that mean a single case agreement? Does it have to be something in writing executed by both parties? I think, and that's for the out-of-network clients that are continuing stay. I think the recommendation there is you should reach out to the plans for whom it affects you for your clients and have a conversation with them. They may all handle it a little bit differently, and I don't think there's any kind of clear-cut one way or another rule on how each plan will handle that issue. The issue is that they will have to pay you for that continuing length of stay, at least for 90 days, and then after that, it's a discussion and following the criteria. But you should reach out to the individual plans and have those conversations earlier rather than later. Okay, there's a number of questions about how will pre-authorization work for clients who obtain Medicaid post-implementation, and whether when they get enrolled in Medicaid. The clients who get enrolled in Pat or Tom, you can correct me if I'm wrong, but clients who get enrolled post-implementation, so post-10-1, will follow the new criteria, and those will go through in depth, program by program, starting on 10-5 and 10-6. If patients have commercial insurance, primary and Medicaid secondary with managed care, are they excluded? Yes. At this point, they're excluded from managed care if they have commercial insurance with secondary Medicaid. All right, and Tom, I know we're going to lose you in a second, but I don't think there's anything that's OMH specific. So I'm going to take one 10-second break here and go back through questions because a number have come in, and I'll read out a couple more. Boris, do you want to take the how would e-PACES indicate HARP status question?
Sure. So it should be listed. There's an exclusion code criteria, or codes, I should say, that's part of e-PACES. I believe, I don't have the code set in front of me, but I think it's code H. You can also go to eMedNI website, and they have a manual with all the code sets, which should be something that all providers have access to. I think it was updated in March or April, and those codes are listed there if you need a reference. So again, you can go to eMedNI or e-PACES that has a code set, but I believe it starts with an H. Okay.
There's another question. This is actually a really good question about the transition, and for folks who are either in, it would apply to like Westchester or Long Island. A client's individual transition to Medicaid is defined by where their Medicaid is registered. So if their Medicaid is registered in New York City, they go live on 10-1, even if the provider is in Long Island or in Westchester. So the transition to Medicaid managed care is not dictated by where the provider is located. It is dictated by where the client is, their client's Medicaid is assigned. So if the Medicaid is assigned in any of the 5 boroughs in New York City, that client goes into Medicaid managed care on 10-1. So if you're a Nassau County or Suffolk County provider, or you're a Westchester provider, you may have a small number of your clients who are going to transition before then, particularly if you serve a lot of clients who live in the Bronx, or you serve a lot of clients who live in Queens. So you're just going to want to be mindful of that some of your clients may be transitioning on 10-1, even though you as your organization, thinking of where you're located, won't be thinking about the major transition until 7-1. I'm just going through other questions. Okay, so there's a question about the matrix and beacon. Beacon hasn't submitted all of their matrix information to us yet, but much of their information is listed under the individual plans that they are covering. So you can find most of the information on, like under Metro Plus, some of their contacts are listed, but they haven't given us all their comprehensive information yet for the matrix. So for existing clients that are in a plan already and they're carved in, there may be some different requirements, and we'll take that back and get back to folks. Is there a suggested format to provide notification to MCOs for existing and transitioning clients? There isn't at this point. If we're able to, working with folks able to pull together a standard format, that might happen. We're glad to take that suggestion back, but at this point, especially given the short time frame, I would start reaching out to the plans, particularly the plans you already have contractual relationships with, and ask them how they want you to inform them about your existing clients. So I would have those conversations with the individual plans. Pat, this is a question for you. Do we need to share locator information with MCOs on existing clients?
There is no requirement to share the locator for ambulatory patients. So because there's no UR in that first 90 days, that will only happen as you start to develop those relationships for intensive outpatient and day rehabilitation patients. You may want to start having those discussions with plans, just to let them know about your program, but you don't have to notify them on a per patient basis. It may be good for care coordination, going forward to begin to notify, but there's no requirement to do that until that 90-day period is over for existing patients.
All right, thank you, Pat. That's very helpful. And then when will the model contract be available for providers to see? And then what supersedes the model? What contract supersedes the model contract with the plan?
So the model contract is going through a review that's required, and we're very close to the end of that time period. I don't have the actual days, but as soon as that review is complete, we will have that model contract available for people to see. And as far as superseding, the model contract that the plan signs with the state supersedes the requirement that whatever the contract language is where there's a conflict between the provider and the plan.
Great. So if there was some error in one of an agency's plan with the managed care company, let's say the APG rates weren't listed or something like that, that would be superseded.
Yes, that's correct, Danny.
Great, thanks so much. Somebody else asked about Queens. I'm just going to clarify this. Clients who are assigned their Medicaid is assigned in Queens. Any of the 5 boroughs in New York City go live 10/1. Anybody outside of New York City goes live on 7/1 next year. And then I have one question Boris is going to take. We serve clients with a primarily Medicaid secondary. In some cases, Medicaid, when reviewing e-PACES, does not recognize the commercial carrier. Do we contact a managed care company, have them recognize the primary commercial payer?
No, you have to go with the client and really go through the Medicaid office to update the Medicaid status. So this is more about making sure that as best as possible, the Medicaid information is accurate. The managed care companies can only work off what the state is identifying in those cases, so you're going to have to work with the clients and so forth. The other thing what I would encourage in general as we talked about e-PACES and looking up e-PACES now, I would strongly encourage clearly doing the e-PACES lookup before October 1st, but then repeating it within the first week of October. As you know, status has changed. There's they're usually changed, or for most part changing on the first of the month. So it's a very good practice, and especially now to check e-paces now and then repeat it again in early October.
If agreements are not signed by 10/1, what rates will be in play for those out-of-network service provisions? The state rates will continue to be in play for those out-of-network things. So if your contract isn't fully defined by 10/1, they're going to have to pay you on an out-of-network basis with the state rates. But you're going to also have to come to some kind of arrangement, as we've talked about before, around how you're going to bill them and those kinds of things. But they won't have to. They will have to pay the state rates. How do you tell where somebody's registered as a Medicaid client geographically?
It should be on their e-paces that identifies their, I think it's called origin of, county of origin. I might be not saying it accurately, but it should be on their e-paces as well.
Okay. Will medical and psychiatric services billed through OASAS be covered? Pat?
Yeah, so this is for an integrated license. The rules and rates around that are will be consistently paid through the integrated licensure. For medical services, the same rules that applied prior will apply after, and in the billing guidance, there's guidance to OASAS providers to use that medical rate code for medical services, but still they have to be a limited amount of the total services that you provide. It can't, you know, so we were tied previous to managed care to 5%, and that would carry over. And then the last question about mental health services is that you always have been able to do codes and services related to the person's substance use disorder that are mental health related in the service of, you know, helping a person to recover, you know, wholly, when you have the staff and the ability, the expertise to be able to provide that service. So nothing will change about that.
Okay, great. Okay, great. There was another question that came in. I'm sorry about when Pat unmutes her phone. I think we get feedback. But there was another question that came in about ensuring authorization during a 45-day wait period for Medicaid pending clients. In general, managed care isn't going to pay retrospectively to beyond.
It will not go retrospective.
It won't go retrospective, but we'll get further guidance unless Pat, you have additional clarification.
No, I agree with that.
Okay. So we'll take that one back and get that answered. Yeah, just to confirm. There is no formal data when the model contract's going to be released, but it'll be available when it's available. And I'm going to take 1 second here and just read through some additional questions. We got Pat for another 5 minutes, so if we got other questions, we'll highlight those as well. All right. I'm going to go see if there's any other questions that haven't been addressed yet that cover the topic today, and then we will wrap up. Yes. Oh, there's a good question about the locator, which I can answer, actually, which I'm excited about. What about mandated mental health services locators for substance use services, correct? Yes. So the locator is only being used for substance use services, for services that are part of the OASAS system. At this point, the locator is not used for mental health services in the mental health system, in the OMH system, and there is not an equivalent type locator-like device being used in mental health. So that, yes, so at this point, the locator is only for substance use services. Whoa. All right, I think at this point, we're going to wrap up. I want to thank Pat and Tom for their time. I know we had a short notice, really tight timeline to get them to be able to be on today, so I really want to thank them for taking the time and getting this information out there to everybody. Just for folks' reference, if you have additional questions, feel free to shoot them to mctac.info@nyu.edu. Our matrix and all of our previous training is available at mctac.org, so please go there and take advantage of that. And then please monitor your email boxes in the next couple days for a notice on the training for new clients on October 5th and 6th. And for those of you who are health home folks, I know we had some health home folks on today. We will be doing a lot of specific training that's going to cover the health home issues, particularly for HCBS services. And the plan of care training will be coming soon, and we'll be announcing that in the next couple weeks, if not sooner. So I want to thank Pat and Tom for joining today. Thank all of you for joining, especially early on a Monday morning. And we will be, please keep notice, with all these things happening, there's going to be lots of email notices coming out of it, additional trainings and opportunities to get information. But please visit our website at mctac.org. And as I said, if you have any other questions, please shoot them to mctac.info@nyu.edu. And with that, we'll wrap up the webinar. So thanks a lot, everybody.
Thank you, Andy.
Thanks, Pat.